This is Katrina Wu, and today we will be talking about Pap smear screening and evaluation. So we'll start by doing a little bit of a refresher from reproductive physiology, talking about the anatomy and physiology of the cervix. We'll talk about Pap smear collection and then interpreting Pap smear results. Then we'll talk a little bit about colposcopy as well as how to interpret those results should a biopsy be collected. And lastly, we'll talk through some of the treatment options if treatment needs to be done for abnormal findings. So here's our review from reproductive physiology. We see this cross-section of the cervix here, and we know that inside the endocervix, cells start out as being columnar epithelium. Then, like a grain elevator, they come down, 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 and as they enter into the ectocervix, they transition from being columnar epithelium over to squamous epithelium. And we call that transition metaplasia, so a normal cell type turning into another normal but different cell type. So that's metaplasia, and we know that this area here we can call the transformation zone from when we're switching cell types. And right here where the squamo-columnar junction starts is where we'll sometimes see ectropy. So in this case you can see that some of this endocervix is visible on the ectocervix, and we call that ectropy. And that's normal and that's fine. We do know that a significant amount of ectropy on the ectocervix is more susceptible to HPV. So when HPV is exposed to that area, it's a little bit more likely to take hold. We'll see quite a bit more ectropy for younger women, and then as they age, it recedes into the endocervix again. So it might be here for a woman who's 50, might be here for a woman who's 20. Being on hormonal contraceptives tend to cause you to have more ectropy visible. But for the most part, it's just a matter of what do you happen to see when you put in a speculum. So here's our cervix. This is what we would see. This is our transformation zone, when our columnar cells here are turning into squamous cells here. All right, so we talked about metaplasia being that normal transition from columnar to squamous epithelium. We call it dysplasia when in the midst of transitioning from one cell type to another, some kind of a change happens that would be unusual. You could think of dysplasia as essentially being a precursor to cancer. So I think this statistic here is a good way to start us out. So there's been a 70% decrease in cervical cancer rates since the Pap smear's initiation in 1950. It used to be that cervical cancer was the #1 cancer that killed women. That's not the case anymore. And now, usually if women have cervical cancer, it's because they've either never had a Pap smear or it's been 10 plus years since they've had one. So that's a huge improvement from a public health standpoint. Cervical cancer is definitely lethal, but it's very, very slow growing. So with us consistently checking in and looking for cervical changes or dysplasia, as we're regularly checking in, we can stop it pretty quick before it would have a chance to develop into cancer. So 48 hours prior to testing for a Pap smear, usually women are just going to come in and say, here I am, I'm ready for my Pap, and you won't have had a chance to mention any of this. So take it with a grain of salt. This is to the extent that we're able to affect how they come in. It should still be able to get a decent reading, but ideally 48 hours prior to testing, women shouldn't douche, which really we never want them to douche, but we don't want any douching. Ideally they haven't used a tampon, they haven't had sex, they're not using any kinds of creams or jellies, vaginal estrogen, spermicides, anything in their vagina. And that last point is basically the same. You shouldn't use a medicine or cream in your vagina. And then lastly, mid-cycle would be the best time for us to test. And again, at this point, given how we're testing, none of this matters to a particularly strong degree, but your ideal Pap smear would have these things in mind. So how good is the Pap smear? We have a conventional and we have a liquid-based method. The conventional method is basically you would get your sample, basically scraping cells off the outside of the cervix there, and then you would wipe it onto a microscope slide. And if there were other substances present, such as if she was on her period, looking under the microscope, you're having to kind of weed through all of that to actually look at your cell type. Whereas now almost everyone is using liquid-based collections, and so it's a lot easier to kind of filter out and filter through extracellular matter that's not actually cervical cells that we're looking for. So any kind of interference, whether that's mucus or blood, etc., you don't have to worry about that interfering with the results. The liquid-based test is also nice because it's easy to co-test for HPV, as well as even gonorrhea or chlamydia based on what your lab offers. So how good is the Pap smear? So thinking about sensitivity and specificity, sensitivity, just as a refresher, that's our true positive. So if she does have dysplasia, we're able to find it. So the sensitivity for that is a pretty wide range, 61 to 95%. So those would be our true positives. So we're not missing it if she's got it. So true positives, are we able to find it? It's a wide range. Our specificity is a little bit more consistent and is decent. So if she doesn't have it, it's our true negative. So if we've tested and she's negative, she really doesn't have it. So that's reassuring. So our sensitivity is I was able to find it and she had it, whereas our specificity is saying if she doesn't have it, I'm really not finding it. So hopefully that helps kind of think through that. Pap smear collection. So there's two different methods. There's the broom, which if you've already been to your first intensive, you'll have practiced this, and if not, know that you'll have a chance to practice this at the first intensive prior to starting clinicals. But for the broom method, you're going to turn your brush clockwise 5 times, and then when you put it into the vial, you'll press it down and swirl it around 10 times before removing it. And then for the second method, you use a spatula and a brush. So this is the spatula, long end goes inside the endocervix, or rests inside it a little bit, and then you do one full 360 turn. And then for the brush, you're inserting it until you can just barely see these outer bristles, and you're turning it just a quarter to a half a turn, no more. And then again, for both the spatula and the brush, you'll put that in the same vial and swish it around, scrape the sides of the brush, and get as much cellular matter off as you can. And that's how you'd collect your Pap smear. All right, so interpreting Pap results. I want you to think of this as a ladder. So basically what I mean by that is you can be a certain finding one year, and then the next year it could be worse or it could be better. So you can go up the ladder and you can go down the ladder without us doing anything. So at the very bottom of the ladder, the least amount of cervical change that we can find is called ascus. And then if we continue to go up the ladder, it would go ascus, then ascus H, then L cell, then H cell, and then I'll talk about these two afterwards. Okay? So pretty much this is our ladder, is ascus up to H cell. HPV is essentially responsible for all cervical cancers unless they're developing cervical cancer that started somewhere else in the body. So if they, say, had uterine cancer that then spread to their cervix, or cancer in another part of their body that then spread to their cervix, this wouldn't be the case. But essentially all cervical cancers that start at the level of the cervix are caused by HPV. And everything here, this ascus H up to H cell, over 99% of that is going to be due to HPV. So the exception is the tier 1 of our ladder. So what is ascus? Atypical squamous cells of undetermined significance. Loosely saying, we found a cell, doesn't look quite right, we're not sure about it. So if you get this finding, it can be because we're on the start of heading up the ladder, or it could be because of chronic inflammation, or maybe recent tampon use, possibly recent infections like gonorrhea or a yeast infection. So just having this, it's kind of tricky to tell exactly what it means. So anytime you're ordering a pap smear, it's a good idea to just say to reflex to HPV if you get an ASCUS result. As in, I don't need to test for HPV, but if it's ASCUS, then I want to know if HPV is here. If it's any of these other ones, I can basically assume it's HPV. I don't need to test for HPV. But if it's ASCUS, I want to know if HPV is there. And if HPV isn't there, more or less you can ignore it. We'll talk about in a little bit how to what to do with abnormal findings. But for the most part, if you don't have HPV, we're not taking this very seriously. Okay, so next one up the ladder is ASCUS-H. So it looks like this one, except for the level of change we're finding with the few cells that don't look quite right. Looks like they might really not look quite right. So the few scattered cells we're finding look high grade. So there's no clustered lesion, but we are finding cells that are looking concerning. And then when we come up here to LSIL, or low-grade squamous intraepithelial lesion, it means we are finding a cluster. So instead of having scattered abnormal-looking cells, we're finding that the abnormal ones are organized into more of a pattern. But the actual degree of abnormality we're seeing in the cells would still be considered low-grade. So then moving up the ladder here, for the high-grade squamous epithelial lesion, we're finding them clustered like LSIL, but the level of abnormality we're finding in the cells does look fairly abnormal, or we'd consider it high-grade. So they're organized into a lesion. They look particularly altered. Maybe it looks like there's a lot of rapid change happening, or dangerous changes happening. So you'll see that from the H cell all the way back down to the ASCUS, those are all talking about squamous cells. So those are all going to be found on the ectocervix. Whereas for the adenocarcinoma, adenocarcinoma would be the columnar cells. So these are H cell to ASCUS. These are all saying we're definitely seeing some change. These two are saying we're seeing cancer. The squamous cell carcinoma meaning cancer essentially of the ectocervix, because those squamous cells are found on the ectocervix, and adenocarcinoma meaning we're seeing cancer on the endocervix, because that's where we'd find columnar cells. If you do have a reading of squamous cell carcinoma, they would categorize it as either being invasive or in situ. And then again, the adenocarcinoma would be inside the cervix, and it would be those glandular columnar cells. So HPV, how does HPV fit into all of this? So we've already established that cervical cancer is essentially almost 100% caused by HPV, unless it came from another part of the body. And when we're talking about HPV, it's a fairly common virus. So we know we've got over 100 different types or strains of HPV, probably closer to 150. So this is how I'd explain it to women. So we've got over 100 types of HPV viruses, and of those, about 40 of them can affect you below the belt. So 150, we're going to narrow that down to about 40, and then of those, we can divide those into two categories. We can divide them into low-risk strains and high-risk strains. Low-risk strains cause genital warts. So the ones that aren't affecting you below the belt, like if you had a wart on your finger, that's HPV-2. That's not going to cause cervical cancer. In the same way, genital warts wouldn't cause cervical cancer. So the low-risk strains that cause genital warts are never going to cause changes to your cervix. And the high-risk strains could cause changes to your cervix that could eventually lead to cancer. So of the high-risk strains, those won't ever cause warts, and vice versa. So those are the two kinds of HPV we'll see. And again, there's multiple strains. So when we look at the Gardasil vaccine is vaccinating against the two most common strains responsible for causing genital warts, or the low risk type, and the two most common strains that can cause cervical cancer, so type 16 and 18, are responsible for the majority of cervical cancers and are high risk types. Okay, so that's HPV. So then for abnormal pap smears, what if we didn't do anything about it? So like I said, you can go up and down the ladder. So 1 year you might be L-sil, you don't do anything about it, you come back next year and it's completely gone, or maybe it's developed into H-sil. So in the context of not doing any treatment with abnormal paps, 33% of squamous intraepithelial lesions will regress, meaning that they get better. 41% will remain the same, and 25% will worsen or advance into more abnormality. So nearly 90% of women with detectable HPV infections will spontaneously clear it within 1 to 3 years. So what we can note from that is even if we're finding that something is abnormal, whether that's being positive for HPV or having an abnormal pap, there's a decent chance that our body's going to be able to clear it on our own. So 33% chance that pap's going to regress. Within 1 to 3 years, most women are able to spontaneously clear HPV, which was the cause of having an abnormal pap smear in the first place. And I think it's noting, particularly in this context, that for young women, they're very likely to be infected with HPV. There's a lot of ectocervix showing, that ectropy on the ectocervix. And then this is also a time in their life when they're more likely to have multiple sexual partners. So between those two pieces, the chances of them having HPV and with that abnormal paps and cervical dysplasia is fairly high. But they're also really likely to be able to clear it on their own. There's a much higher turnaround of cells when they're younger. And so the danger is that if we start papping women too early, and if we're finding cervical dysplasia potentially scooping that out of their cervix, we can cause a fair bit of damage to their cervix from a young age when really their body be able to spontaneously clear it on its own. So it's pretty rare for dysplasia to develop into cancer. It takes about 8 years to get to the point of being HPV positive, to then starting to see changes on your cervix, and then to have those changes develop into cancer. So it's a very, very slow growing cancer, but it is deadly. So in the context of women having regular pap smears so we can check in on it, it's really uncommon for women to die from cervical cancer anymore. So we've got a little time, I guess is what I'm saying, and there's a decent chance that women's bodies can heal themselves. So what are the guidelines? So these are the pap smear guidelines based off of the most recent ones that came out in 2012. And what I'm showing you here is consistent with ASCCP, which is basically the national group over colposcopies and cervical cancer, the United States Preventative Task Force, and ACOG. So all of them agree with what I'm talking about here. When do we start pap smears? We start papping women at age 21. Doesn't matter if they're sexually active, doesn't matter if they've been sexually active since they were 15. We're waiting till 21 to start papping. Throughout a woman's 20s then, we're going to pap every 3 years. Once she hits 30, we've got two options. Option 1 is to just keep papping every 3 years. If from age 20 to 65 you papped a woman every 3 years, that would be 100% appropriate. However, once we hit age 30, we've got a second option, and this is really the preferred option. So every 3 years in your 20s, but then when you're 30, add a co-testing for HPV. So every time you order a pap, you also say, also test for HPV with this pap. And if her pap is fine and she's negative for HPV, you can space it from every 3 years to every 5 years. because again, if HPV is not even there, to get from the point of having HPV be there to then HPV causing changes to your cervix to then that developing into cancer takes a long time. So if she's not even positive for HPV, let's space it out. So do we ever stop? Yes, at 65 we stop, assuming we've got an adequate screening history. So if in the few years leading up to her turning 65 we've had a few abnormal PAPs, let's not stop right away, but if it's been a long time since she's ever had an abnormal pap smear, it would be appropriate to stop at age 65. And once you've stopped, you don't start up again. So there's a little bit of mixed research on this, or suggestions on this, but one thing to keep in mind would be, what do you do if a woman's had a hysterectomy? So first of all, if a woman's had a hysterectomy, they may have left her cervix there, and if they did, then you're going to keep doing PAPs every year. But if the hysterectomy involved also taking out her cervix, then you would stop doing pap smears. So the part that's a little bit debatable then is, what do you do if the reason her uterus was removed was due to cancer? So if she had endometrial cancer and her uterus was removed and there's no cervix left, some studies are suggesting that we should continue to pap, and you wouldn't really have a cervix to pap, but you can see like a line of staples at the end of her vagina where it's been essentially pouched off, and that's what you're going to pap. So you could take perhaps the spatula and just scrape it across that line where the staples were, where you can see that it was pinched shut at the back of her vagina, and send that off for the pap, and you can see if there's abnormal cells there. So again, you're only doing that in the event that a woman had a hysterectomy because of cancer. And then I've got the link there so you can see the guidelines that kind of compare all three, the ASCCP, United States Preventative Task Force, and ACOG. But all of them would agree with what you see above. So that can be what you put to memory and take with you to clinic. So how are we doing as midwives? Are we under screening or are we over screening? So this study is a little bit outdated. It's 2008, but the general principles in terms of how often we needed to be papping still apply. That's still consistent, even though there has been some changes for cervical screening guidelines since 2008. So what the study did was they asked OBs, midwives, and women's health NPs if they would pap different women. So there were a bunch of different case studies. And for each one it said, would you pap this woman or would you not pap this woman? And so I just pulled a couple of them to give us a little bit of an idea here. So we have an 18-year-old woman who isn't sexually active. Do we pap her or don't we? So the screening rates that were reported in this study, one of the groups was 23% said yes, we would pap her. One of the other groups said 36%, and one of the other groups said 74%. So which one would you guess are the midwives? So we were the 36%. Women's health NPs did it 23% of the time. We did it 36% of the time, and OBs did it 74% of the time. So really, this woman shouldn't be papped because she's not 21 yet, and especially because she's not sexually active, but just being 21 period would be enough. And then we can see in this next case study, an adolescent within a month of onset of sexual activity, and 58% of the women's health NPs said they would, 70% of the nurse midwives said that they would, and then almost 95% of OBs said that they would. And again, this woman shouldn't be papped. Even if she's sexually active, we should be waiting until she's 21. So I guess my take-home message from this is that you might find that you end up at a site where they're not doing pap smears according to current guidelines. And I want you to know that your current preceptors are receiving CEUs because they're working with you. Yes, you're learning from them, but it's also recognized that you're bringing to them the freshest information. So having students, myself included, means that you're bringing people who are well-versed in all the current literature and the freshest guidelines, and that helps improve our practice as preceptors. And sometimes you might find that you're at a site where you can make some change. Sometimes you can't, and you just need to make a mental note of once I'm out in practice, I'm going to do it differently. But I'd encourage you to bring your guidelines with you and to show them, and you might even be able to make some change. So that's my little encouragement for you there. No, when I was a student, the first site I was at, they were PAPPing 17-year-olds. And I was not able to make any change, but I hope more for you. I also think it's worth thinking about how our work as nurse midwives, most people think of us in the realm of pregnancy and birth, and we have a reputation for doing the least amount of intervention that's necessary. That's one of our hallmarks. But that really bleeds over into women's health as well. So PAPPing everyone every year is really expensive. A lot of places are still doing PAPs every single year, but we've recognized as a country how, and really as a planet, how slow growing HPV is, and it really isn't necessary to be PAPPing everybody every year. And we'll talk about how in the context of abnormal pap smears you might be doing it more often, but in the context of routine screening, PAPPing everyone every year is expensive and it wastes healthcare dollars. And it also increases anxiety. So thinking about PAPPing a 17-year-old who then finds out she's positive for HPV and has an abnormal pap smear, that's going to mean more follow-up visits. Treatment might involve damage to her cervix, when if we'd waited until 21, her body probably would have cleared it on her own. Okay. So we're going to keep going here. So what do we do with abnormals? So I've got the link there for you for the ASCCP guidelines. I think it's around a $10 app and a $7 booklet that are available. If you buy the app, then if/when guidelines change, you'll automatically get the freshest ones there, so that's nice. But if you like having something in your lab pocket better to flip through, then you can do the booklet as well. And I would really encourage everybody at least buy one or the other. Pick one. It's the sort of thing you're going to regularly use. I've got the app and I use it regularly in clinic. And then you can also look up the algorithms for free online. So you can pull those up even if you haven't bought the app or the booklet. General principles, really look to the booklet every time, but general principles are that anyone with a positive HPV 16 or 18, those two most common types to cause cancer, you're going to do a colposcopy, which is where the cervix is looked at more closely. We'll talk about that in a bit. And anything else or higher tends to be a colposcopy. All right, so I want us to just look through the guidelines together here so you can just get a little bit more familiar with how to read them. So this is the free version that's available online, and if you order the booklet as a hard copy, this is what it would look like. Okay, so basically you just flip through the different slides and it gives you examples of what you might find. So in this case, management of women over 30 who are cytology negative, that's your pap smear, but HPV positive. So remember, we're automatically testing for both every 5 years starting at 30. So their pap looked fine, the cytology looking at the cells themselves, but they're HPV positive. So option 1 is repeat co-testing at 1 year. That's acceptable. So just do it again in a year. So her next pap's due in a year, leave it at that. Other option is to do HPV DNA typing. So a lot of times when you order the HPV to automatically be done, and you can say that if it is positive for HPV, to have it reflex to testing what type it is. And if it's 16 or 18, then go ahead and do a colposcopy. But if it's not, then go ahead and test again in a year. So then in this case, if we've tested again in a year, and the cytology is negative, HPV negative, repeat co-testing in 3 years. And then if that's fine, then you can go back to the every 5 years. Whereas here, if we're ASCUS or HPV positive, or anything worse than either of those things, then we'll just go straight to colposcopy. All right, so let's just see what another one might look like so we can get used to looking through the table. Okay, here's ASCUS, so Management of Women with Atypical Squamous Cells of Undetermined Significance. So we can either repeat cytology in a year, that's fine, or preferred would be to have also done HPV testing. So that's why anytime you order a PAP to be done and you're not automatically doing HPV, like if she's 25, then you're going to say HPV, you're going to say that you want to reflex to HPV if ASCUS. So in this case, let's say we did do that because that's the preferred method. Then the pap smear comes back ASCUS and HPV is negative. Great, we're going to go again in 3 years, which would be typical if you're in your 20s anyway. If it's positive though, then, and it puts in parentheses, would be the same as if she was also, we're going to go to a colposcopy. All right, and then let's check again. Management of Women 21 to 24 with ASCUS or ELSO. We can either test again in a year, or we can reflex to HPV. In the case of it being ASCUS, because we wouldn't need it if it was ELSO, we'd assume it. And if she's HPV positive, repeat testing in a year. You can kind of see how you just follow the algorithm. It's just about following the algorithm. So ELSO, you can see all the different ones we had are on here. If it's ASCUS H, then we're going to go ahead and go to colposcopy. We'll talk about colposcopy findings later. That's a lot of colposcopy. HSIL, basically you're going to send them for colposcopy. Alright, so I'm going to leave it at that and let you kind of look through that yourself and get comfortable with it, and then your quiz this week will be on being able to maneuver it. Okay. Next slide. Miscellaneous. Okay, so we've pretty much already talked about reflex HPV testing. We're just doing it in the event of ASCUS. But then you can also reflex for what type of HPV too. HPV typing to see if it's 16 or 18. You might find on your PAP results that it says absent endocervical cells. So usually what you need to look for, when I look at PAP results, I look for two things. It'll say something like adequate sample, and then it will say what the finding was. So if it says adequate sample, no, or adequate sample, absent endocervical cells, or unsatisfactory for evaluation, or transformation zone wasn't present, something like that, then even if it says your PAP is negative, you don't really know that because you didn't have the right kind of cells in your sample. So maybe that had to do with just not getting a good enough sample. Maybe it had to do with the transformation zone is receded so much into her cervix that it's too hard to get a good sample, that kind of thing. Sometimes they'll issue you a report once a month, depending on your lab, saying, FYI, this is how many adequate samples you gave us by provider. So you might see something like that too. Something else they might note is like dead trichomonads. Well, I guess I'll say if they find trichomonads, know that they could only find dead ones. And we're only treating based on live ones, but you could have her come back in and test for that to see if there's live ones. So you're not treating that based off of a PAP, but that could be an incidental finding that they note. They might also note that they found endometrial cells. So that would be a normal finding if you have a menstruating woman, anyone really into her 40s. But if she's in perimenopause or has some kind of dysfunctional bleeding, or maybe she's been postmenopause for a while now without any bleeding, that can be an abnormal finding and would be worth following up on. That's not why you did the PAP, but if they found it incidentally, it would be worth following up on. So an endometrial biopsy would be how you would detect for endometrial cancer, but that would be something to think about for those women. So consider women's reactions to abnormal pap smears. What does it mean that she has a midwife as her women's healthcare provider? How does that look different? There can be a significant amount of anxiety over abnormal pap smear results, and our education and framing things in light of what's worth worrying about and what's just worth keeping an eye on is important. I don't know that I would ever say it's worth telling her that it's worth worrying about. But I think we use a lot of terms that can sound really scary. So we say it's a precancerous lesion, or ASCUS says that it's cells with undetermined significance. And for somebody that's not familiar with healthcare, and I would say even most that are, this kind of terminology isn't particularly common or widespread. It's important that we frame it in light of, at the very least, understanding how slow-growing dysplasia tends to be, and how, in the context of us following up, it's pretty rare for women to actually develop cervical cancer in the context of us frequently following up, and we'll talk about treatment here coming up too. There can be a lot of anxiety around how HPV was acquired, particularly if it's a couple that's been together for 20 years and she believes it's been mutually monogamous, to all of a sudden find out you have HPV. It could be that she got it when she was 18 and it's just been hiding, and again, we use the term immunoevasive because dormancy still kind of implies we can find it, but it can just kind of hide from us and be undetectable for a long time and then pop up. So it could be that something happened recently, but there's also a good chance that it was something that's just been lingering from one of them for a really long time, and it's just now starting to show its face a little bit. I think for the mode of result notification, it's really worth calling personally. I think if they're normal PAPs and it's just saying, hey, you'll get your next one in 5 years, that'd be fine for your nurse or whoever else might make some of those phone calls in your office. But if it's an abnormal PAP, I really think that's worth you calling as the provider personally. And then lastly, there's been some studies to show that women having abnormal pap smears, that can affect their sex lives for up to 5 years. So realizing that just finding out it was abnormal can have a really big impact. So our role really is to lessen anxiety and depression around this and provide information on the prevalence of HPV and ultimately the low risk of cancer. So by age 50, it's actually 80% of women who've been positive for HPV at some point in their life. It's really, really, really common. So again, within the context of us checking regularly, it grows really slowly, and we should be able to stay on top of it without a problem. So what is a colposcopy? Colpo means cervix, oscopy means look at. So basically it's just us looking at our cervix more closely. So you put in a speculum, and then this microscope here is pulled right up to it, so you can really get a good look at the cervix. So it's looking at a cervix under a microscope. This would be something that wouldn't be part of your baseline scope of practice as a midwife, but it is something that you could add. So ASCCP, the American Society for Colposcopy and Cervical Pathology, they're the national organization that puts out guidelines for pap smear recommendations and follow-up. 12% of their national organization is made up of advanced practice clinicians, and 6% of midwives have gone on to do this extra training to become colposcopists. So if this was something that you are wanting to add to your scope of practice after you graduate, it's usually about a half a week to a week-long conference where you learn about it and learn the didactic side of colposcopy. And then after that point, you'd be able to work with a colposcopist for a little while, doing colposcopies together, and then you'd be on your own. It's a great revenue for any practice, so if this is something that interests you, it's definitely something that your employer might be interested in paying for the training for you to go on to do this. And I think for women to have that continuity is just beautiful, because you're somebody that she trusts. And so for you to have walked her through initially having an abnormal pap smear to doing her colposcopy as well, just keeps her in a really safe environment and comfortable environment, because our moms trust us. So what is the colposcopy doing? So we already know that we're looking at it under a microscope, and then basically what happens is a weak vinegar solution is sprayed onto the cervix that dehydrates cells, causing the abnormal cells to turn white. So this is what normal is looking like, and then You can see how, depending on how severe it is, you could the whiteness would stand out more. So I think it's helpful, even though right now you're not planning to be colposcopists, it's helpful for us to understand what colposcopy is so that we can explain women what's going to happen. So some women say that it burns just a little bit, but it's typically not uncomfortable. So it's just about potentially having to have the speculum in for a little bit longer. And I think it's important that we are the ones that explain an abnormal pap result to clients before we're referring them, so that they already kind of have an idea of what's going on before they walk in the door. So a cervical biopsy, just because you had a colposcopy doesn't necessarily mean that you'd have a biopsy. So I'm going to go back to this slide again. If she goes to a colposcopy and they spray on the weak vinegar and her whole cervix looks like this, then nothing's going to happen. But if they see this, then they might take a biopsy of this area to understand better what's going on. So this is the instrument, the biopsy forceps. And then generally speaking, if a biopsy is needed, women might feel a little bit of a pinch or they might not feel it at all. So again, that's kind of nice anticipatory guidance for women. So they're just cutting a little pinch out of whatever area looks concerning. So how do we read those results? So I want to actually start here. So a pap smear, we're just looking at individual cells we've scraped off the surface. So individual cells, or cyto, would mean a cytology result. So pap smear results are cytology results. That's where you see ascus, L cell, H cell, etc. Colposcopy, we've gotten this tissue sample. So it's not just individual cells, it's a chunk of cells that normally function together. And tissue is hist, so histology results. And that's where we see what we're reading above about the CINs. So when we look at CIN results, if we've sent a biopsy from a colposcopy, it could just come back as normal or perfectly clean, or it could come back with a CIN result. So CIN1, if left untreated, about 1%, will progress to severe dysplasia or cancer in a year. So again, CIN isn't cancer. CIN is still precancerous, but it's still not to the point where it's even severe dysplasia. Versus CIN2, about 22% will progress to severe dysplasia or cancer in 5 years. So most pre-invasive cancer, so CIN2 or 3, will develop into invasive cancer over a period of 10 to 12 years. So you can see this is really slow growing. So we're able to catch it here, we can stop it here. Cure rate is, when the cancer is localized, is about 90% versus 50% if it's invasive. So if we find it and it's already cancer, the cure rate's pretty good, assuming that it's still in situ or in place and hasn't become invasive. So based on what's found on biopsy, then you can decide how it needs to be treated, and the ASCCP guidelines will tell you exactly what should be done. So if it needs to be treated, there's 3 basic ways to go about it. Chemically destroying the cells, typically an acid to burn it off, and that's not used very much, so that's all I'll say about that. Surgical ablation would be like cryotherapy. That tends to be done more in developing countries, and I'll talk about that in a little bit here, but isn't done as much in the US. And then surgical excision, almost everybody is going to have a LEEP procedure, so especially when you're getting histories, even if they don't feel very comfortable around the terminology around pap smears and what was going on with their abnormal pap smear, usually they'll recognize the term LEEP. And then a different form of a surgical excision would be doing a cold knife conization. So I guess the last thing I'll say here for the surgical ablation or cryotherapy is that oftentimes in developing countries, if women aren't in a position to be able to have regular pap smears, you might see a colposcopist just kind of set themselves up, and a woman comes in, this might be the only time anybody ever looks at her cervix, and they'll make it like a one-stop shop. So instead of doing the pap smear and then if it's abnormal, having her come back in and getting a biopsy, and then if that's abnormal, having her come back in and doing one of these treatments, they'll just have the woman in front of her. They'll spray vinegar onto her cervix, look at it. If something looks abnormal, they'll use cryotherapy, and which is basically like freezing it off. And they'll freeze it off, and then she can go on her way and doesn't need any more follow-up. And it's just kind of a one-stop shop kind of a situation. So if that's of interest to you, that would be even potentially worth exploring for your master's capstone. Something to think about. But there's a lot of research that's been coming out on that in recent years, and some really creative stuff. So if you make that your master's capstone, you should request me as your primary advisor. All right, so surgical ablation, cryotherapy, I'm just going to go through some of these so it looks familiar. And again, a lot of this is just not because you're ready to do it, and if you want to do colposcopy, you can go on to do colposcopy, but I think if you're sending a woman off to get a LEEP procedure or whatnot, it's helpful for you to understand what might happen. So you can see the instruments here for cryotherapy, and based on how much abnormality you were seeing or where you were seeing it, you can kind of pick the shape that fits. With what makes sense. So you pick your instrument, and then it attaches to a gun, and then frozen nitrogen runs through it, so not out the top of it, but through it in a way that makes the part at the top here really, really, really cold, so it freezes off the tissue that it touches. So it can be hard if it's too large a region that's abnormal, but again, just pick the best instrument that makes sense for what you're seeing. Women who have this done typically will have a watery discharge for around 6 weeks as those cells continue to shed and die, so that's kind of helpful for them to know as well. All right, so LEEP procedures. This is what's mostly done in the U.S. So LEEP stands for Loop Electrosurgical Excision Procedure. So there's this instrument here that has electricity running through this loop here. And basically you can see from here it's just scooping off the end of the ectocervix. The patient's typically anesthetized. One benefit to doing it this way is you actually have something you can send to the lab when you're done, unlike cryotherapy. So you can scoop this off, and then the lab can confirm, yes, you've got all the borders of what we were seeing where there were abnormal cellular changes. And they can tell you if you got it all. The literature is mixed in terms of long-term outcomes with LEEP procedures. We know that it's really effective, so 91 to 98% success rate. It's about 5 to 20% have recurrence, which if HPV is still there, if they continue to have ongoing exposure, there's no surprise that there's a bit of a recurrence rate with it. But for the most part, it works great. But in terms of long-term effects, possible preterm labor or an incompetent cervix, so having a hard time staying closed once we've got a baby on the other side, potential low birth weight babies. And again, the research is a little bit mixed on if it causes those things, but one thing that we definitely do know is that if it's done repeatedly, so if somebody's needed to have multiple LEEP procedures, then those risks definitely should be accounted for. I know one thing I've noticed, like if I'm taking an initial new OB intake and somebody said they've had a LEEP, it's worth noting because sometimes during a birth, I found that a woman looks to me like she's at 7 or 8 centimeters, but if I check her cervix, she's only maybe a 3 or 4. And if I can just kind of massage it, sometimes there's scar tissue around where the LEEP was done, and if I just kind of stretch it with my fingers a little bit while I'm doing a cervical exam, it'll all of a sudden just pop open, and then we arenate, which is exactly what she looks like, and then pretty soon we have a baby. So not saying you would need to do that, but several times I've had that experience where a little bit of adhesion or scar tissue from having had a LEEP makes it a little trickier for her cervix to dilate in labor. So just something to keep in mind. Okay, and then a surgical excision is basically the same idea as a loop. It's typically done at a surgical center. There's higher bleeding rates for doing it this way versus if you do a LEEP procedure. And there's also higher rates of second trimester abortion. or miscarriage. So you can see that you're basically cutting out the same area that you were aiming to get with a LEEP, and it ends up looking like a cone. I've got one more picture for that too. So again, the cone biopsy, and you can see it's like we're just trying to cut out that whole transformation zone and catch any of the cells that might be part of what's going on that's abnormal. All right, so I guess the last thing I'll say is oftentimes you don't get to be the person who first started doing PAPs with them at 21 and now they're 45 and we have something abnormal. Usually we're meeting women in the crossroads of them having seen many providers. So how do we get an adequate PAP history? So I usually would start out with something like, have you ever had an abnormal PAP? And if they say yes, do you know what it was? Do the terms ASCAS or LSIL or HSIL sound familiar? And usually they'll say no. And then you can say, do you remember if you had to have a colposcopy? That's where they would have put in a speculum and had kind of a microscope instrument to look at it closer. And they might say yes, or they might say, no, I just had to go back the next year for another PAP and that one was fine. Okay, that gives me a sense of how abnormal or normal it was. And then if they say yes to a colposcopy, I'll say, do you know if they needed to collect a biopsy? And usually women will say, yes, they did, but it was fine. And then all my PAPs have been fine since. Or they might say, yeah, I think something was abnormal from that. And then I'll say, do you know if you had a LEEP procedure done from that? And I'll say, oh yeah, that's what it was called. It was a LEEP. So if that kind of helps you think about how you can tease out some of that history. And then otherwise, I think if you're the one that finds it abnormal, give them the long lecture I just gave you, maybe not all 60 minutes of it, but give them a basic understanding of cervical physiology and help them understand what HSIL means or what ASCAS means. Give them the real terminology so that they can navigate it. We want to put women as being in the center of controlling their own health care, and some of that is just understanding the terminology around it. So they don't need to know all the terminology, but I think understanding the terminology around what's going on with them and their situation is important. And taking the time to do that is, I think, what it means for them to be seen a midwife for their women's health care. And the same goes for women who are coming to see you for their very first PAP at age 21. Take the time to explain how you're collecting a PAP and how it will play into her health care. What it is we do with PAP results that'll help her navigate the healthcare system for a long time moving forward, whether or not she's seen you. All right, so go out and prevent cervical cancer.